Shown here is the lateral view of the fifth metatarsal and other structures in contact with it, including the peroneus brevis and tertius tendons, the plantar fascia, fourth metatarsal, and cuboid, all of which are vital to the role of the fifth metatarsal in maintaining the tripod effect of the foot. This bone receives its blood supply from arterial branches of the dorsalis pedis, posterior tibial, and peroneal arteries.
There is a strong correlation between age and gender and type of fracture. Women in their 50s and older account for over half of Zone 1 and Zone 3 fractures, whereas boys roughly 25 and younger account for the majority of Zone 2 fractures. They can be difficult to diagnose in children due to multiple growth zones. Persistent pain in comparison to an uninjured foot is often helpful to diagnose young children.
Fractures of the fifth metatarsal are unfortunately among the more common lower extremity injuries, likely because it's highly mobile to accommodate full range of motion in the foot during gait cycle. For this reason, fracture can result from alterations to metatarsal head positioning, tension overload, and twisting, each of which occurs in a particular region of the bone. Injury caused by turning the foot inward and straining the lateral plantar aponeurosis predominantly affects the cancellous region of the metatarsal base of the tuberosity, while a force directed laterally across the forefoot with the ankle plantar flex puts an athlete at risk for fracture in zone 2, more distal to the base. Intense repetitive activity or an impact force coupled with twisting can injure the shaft of the metatarsal at zone 3. Generally, a physical exam of a patient with a suspected fifth metatarsal fracture may indicate a combination of both swelling and tenderness localized to the injury site, as well as bruising and discomfort that increases with walking. Most important to assess for is presence of broken skin that would indicate an open fracture, and abnormal positioning of the toes, which could be evidence of displaced metatarsal heads resulting from fracture. The patient's sensation could also be checked in the event that a fracture may be causing obstruction to the toe's blood supply. As previously noted, 3 types of fractures are common and are classified according to which zone of the fifth metatarsal they affect. Fractures in Zone 1 are commonly referred to as dancer's fractures, and Zone 2 fractures are known by the term Jones. In Zone 3, they are simply called diaphyseal fractures.
The first type of fracture is the avulsion fracture. It's common among dancers and tennis players. It occurs within the Zone 1 region, which is the most proximal region of the fifth metatarsal. An avulsion fracture is typically caused by the peroneus brevis or the lateral cord of the plantar aponeurosis pulling upon the most proximal point of the fifth metatarsal. This fracture typically occurs by a direct blow or sudden inversion of the hind foot with weight on the lateral metatarsal. This places tension along the soft tissue insertions of the fifth metatarsal base and leads to an avulsion of the tuberosity. Treatments include rest, ice, and elevation, typically only requiring a boot that allows weight bearing necessary for about 8 weeks, heals symptomatically in 3 to 6 weeks.
Jones fractures, also known as Zone 2 fractures, occur at the metaphyseal-diaphyseal junction and are transverse in nature. They are typically caused by stress placed across the bone when the forefoot is planted in plantar flexing. It can also occur from a stress fracture that never properly healed. Jones fractures are difficult to heal because that area of the foot lacks significant vascularization and thus is at risk for non-union healing. Pins are commonly surgically implanted into the fifth metatarsal. Research has shown implanting a pin early can reduce recovery time from about 14 to 15 weeks to as little as 7 weeks, as well as significantly reduce rates of refracture. Regardless, walking boots are often worn to lessen the impact. Jones fractures are most common amongst athletes, particularly in basketball and football. Kevin Durant is most notable for his Jones fracture approximately 2 years ago, but other players who have suffered from Jones fractures include Brooke Lopez, C.J. McCollum, and Rasheed Wallace, whose Jones fracture helped end his career. In addition, Dallas Cowboys wide receiver Des Bryant also suffered from a Jones fracture.
The third type of fracture is called the metatarsal diaphyseal stress fracture. It occurs within the Zone 3 region of the fifth metatarsal, which is the proximal region of the shaft. The metatarsal shaft fracture is typically caused by a direct blow or twisting force upon the bone. It results in an oblique or transverse type of the fracture with minimal displacement. There are 3 different types of fractures, and the first type is an acute fracture without pain, which usually requires non-weight bearing and a cast for about 6 weeks in order to heal. The second type of metadiaphyseal stress fracture is an acute, painful, and often aggravated by activity, typically resulting in delayed healing or non-union fracture due to the fact that the fifth metatarsal has poor blood supply in the diaphyseal region, which would mean that screw fixation may be the best option to reunite the bone. The third type of metadiaphyseal region is determined by complete obliteration of the medullary canal of the bone, which would mean that screw fixation or bone grafting would be the best option to heal the bone.
Although surgical intervention is mostly avoided except in extreme cases, it tends to be successful for patients whose bone fragments are not anticipated to heal in the correct position or for athletes who need to accelerate healing. Most fifth metatarsal surgeries target zone 2, where Jones fractures occur, since the region has the highest rate of non-union and can refracture easily even if it does heal. These procedures typically involve an incision made at the base, followed by fixation of a screw through the fracture site to join the bone ends together. Surgery following a stress fracture in zone 3, sustained by an athlete who wishes to return to play quickly, occurs in a similar manner, but often with addition of a plate for use of hooks or screws. After the operation, risk for refracture is not high, but may increase for patients with a higher arched foot or an inwardly turned heel.